Big shoe to fill for me. So again, I'm Cheong. I actually ran a project at UC San Francisco Medical Center on what I call workflow AI, and you'll hear more about it because a big part of this presentation is all about that. And I'm also the co-founder and CTO of Lucidact Health. So it's very privileged to be here to talk to you about what we do and what we accomplish both at UCSF and part of it is Lucidact. And a little bit more about me, that's my picture. But I guess what it is was a couple of years ago, we successfully meet the milestone of rolling out AI assistant to multiple clients, and NASDAQ, in honor of that, right, give me a few minutes of fame on the New York Times Square Tower. So we got that pictures, and I'm very proud of it. So I also do, several other things, including I was engaged in consulting engagement to provide this healthcare innovation product innovation strategies and to San Francisco General Hospital and Continental Business Innovation Center. And I mentor startup companies at NASDAQ as well after I graduated from the program. And then I also write about AI in healthcare, Lucidact.com. So for today, okay, maybe before I start, how many of you are in healthcare? I know Greg is. Okay, one more person. Wonderful, wonderful. So the takeaways here, I want to start with the end goal in mind. This is what I'm going to cover. So to begin with is workflows and AI, or analytics and workflow, they come together. Right? So I would want to make a statement that healthcare workflows need AI and analytics. And the other way around is true as well. AI and analytics in healthcare, right, will make a lot more impact if it is in the workflow. And then I'll share some of my observations and experience deploying our AI into the healthcare workflows at San Francisco General / UCSF and other clients. And what works, what doesn't, and then the one way that we have transformed what we see at our client site. And I'll give you a glimpse of the picture. So why do I say healthcare workflows need AI? So this is today's world, the EMR as the center of the universe. So EMR is electronic medical record system. Just for those of you who are not familiar with the healthcare industry, that is the system that your doctors and nurses are tagging along, on the keyboard when you are at the hospital and at the clinic visiting them. They spend a little too much time on it, but the system itself is designed for data entry, retrieval, and also for practice management, right, scheduling, and for claims, filing claims with the insurance company. So with that in mind, a lot of those tasks, workflow tasks, centered around that kind of things. It's not really patient-centered, right? And so with that, well, our creative clinicians, the doctors and nurses, I see one, the doctors and nurses are thinking, how am I going to provide my patient-centered care without losing a heartbeat, right? I want to make sure I do a good job. Then they come up with some creative patchwork that you'll see some of it. So to set the stage, I'm going to share a couple of use cases from two of our deployments. So the specialty care clinics, you can think of it as diabetes clinic or pulmonary clinic in our case. The process starts from referral to perhaps a face-to-face visit, to testing, treatment, and for chronic disease patients, obviously, that follow-up period, it goes on indefinitely. And then the second use case that I'm going to talk more about is chronic care management. And this is specifically related to the Medicare Chronic Care Management, the CCM program. And so what it is it involves the nurses identifying the patients who are qualified for the program. And then what they would do is they do multiple outreaches. Right? Perhaps the first time around you don't get the patient on the phone, and you may have to try again, right? Even after the first rejection from the patient. And once you sign up the patients in the enrollment period, then certain things that you would do monthly, like reviewing the patient data and appropriately making the phone calls with the patient and have the telehealth account. So as you can see, those two use cases share several things. The one thing is it's a long-running workflow. It doesn't end when the patient shows up and when the patient leaves, right? It is all about how do I track the patient over time. And then the second thing that they share is because of this idea of patient-centered care, our nurses and doctors want to provide. They ended up doing manual tracking, spending a lot of time to research multiple systems, and also to make sure that everyone is on the same page so they can coordinate their actions. So they are struggling with the misses versus wait time. What do I mean by that, right? Well, when you have to do so much work to make sure that you do every single thing for every patient, that takes away from their patient care. And if you overdo that, then you have only so much time for the patients. That results in long wait time. So the next time somebody calls up, you're going to be like, the next available appointment is 4 months out. So what do they end up? Remember the creative patchwork that I was talking about? Excel spreadsheets, papers, emails, phone calls. So they start sending around, that's what I see about this patient. I'm tracking in my sheet. I send it over to you, and let's get on the phone and talk about that, right? So you can imagine how that goes out. And one thing is probably obvious, especially to this audience, the machine can do a better job. What about how to deploy AIs and analytics into the workflow? On this slide, what I'd like you to think about is perhaps that workflow step one is, generically speaking, right, is the clinician, could be nurses or doctors, reviewing the chart of the patient and entering data. And then the second step might be their way of talking with the payers, insurance companies, perhaps get a pre-authorization. And then the third would be ordering of a treatment of some kind. And so with that, then you have this really cool analytics that you think is really useful. Where would it go into? So the reasonable or straightforward way of thinking is, well, you already have the EMR in the first step over there. It belongs there. Yeah, sure. You know, obviously, if it goes in there, it's right in the workflow, they're working on the patient, and you show this thing. And I like to use the sepsis example. You know, sepsis is some kind of infection that could cause life, right? And so if you have a patient coming in, being hospitalized, then here comes a sepsis warning to you, right in the workflow. But we have also seen, there's another observation. In the workflow itself, that's a CDS, stands for Clinical Decision Support. The CDS act in the workflow itself. What this means is the clinician is on the EMR, working with it, and then they probably bring up another application on the screen itself. And this time is completely different application, and it gives a sepsis prediction. Why do you need that? Right? We just went through the first scenario, which makes a lot more sense. But what it turns out is this is an actual study and observations that we have done. what it turns out is when the first case over there, inside EMR prediction, turns out to be not so relevant, or the false positive is too high. Right? So the nurse looks at it, and the irrelevance part comes from if I already know the patient is at risk of sepsis, and you keep showing me that. And then the false positive part comes from if you keep making the wrong prediction. Then over time, I just learned to ignore it. And then here comes a second app in the workflow. Once I finish typing in what I need to type into EMR, I check with this. And this app is good. The prediction is great, at least for my usage 90% of the time. Then I'll go to that. So what do we learn from this? The obvious thing is, of course, the insights has to be relevant. But the second thing is a little counterintuitive, right? Because a lot of doctors and nurses said, well, we have too many apps, right? Besides this EMR, I got to deal with all this Exchange, the whole Microsoft stuff, right? And now you give me one more thing to use. I just can't learn that. But counter to that, with this study, what we saw was they're actually fine using another applications as long as the benefits are clear. So another point to share. Early on in our deployment of our applications, we thought, remember, our goal is to use analytics and AI to track patient statuses and then to surface those patients and the different actions that need to be taken on the patients so that they could be receiving better care. And so early on in our deployment, we wrote out this. We thought it's pretty cool, or at least I thought it's pretty cool. Right? That we have a diagram that looks like a little subway station, diagram. And what it is this is a patient pathway. And it sort of represents the workflow the clinicians are following as well. The colored stations, if you will, where the patient has been. And then the blue path is the pathways that the patient has been taking. So, well, to me, if you want to know anything about the patient, you just click on the node, click on the station, and they'll tell you everything. And then it's clear enough where the patient is from this diagram. And then also, to make things even better, we provide a timeline of all the different events about the patient. But our nurse Mary just took me aside and said, how do we use this? And so I learned that, well, this is not the way she's working. How she's working is she comes in the morning and she's expecting a list of things that she needs to take care of. And those are the important tasks of the day. And so unless I'm able to say, here are the important tasks about this group of patients that you care about, and if you just do that, then they're taken care of. That's not being helpful to her, right? So this is what we came up with. In the background over there is the My Task list, and that's what she likes to use. And in fact, it's personalized for the different team members. They play different roles, and they all have different task lists. And different than the typical EMR systems, nobody needs to assign any task to anyone. So this thing is run by that machine that's watching patient statuses in the back there, and they knows who's used for what. And it's not even just about closing gaps in care, right? Closing gaps in care is this diabetes patient needs his eyes checked out, then that is one little gap over there that you need to somehow find ways to get it closed. But this thing is about who is responsible for calling the patient, who is responsible for scheduling the patient for that appointment, and which doctor will be seeing the patient. So when I was talking to the CMIO of San Mateo Medical Center in the Bay Area, he was like, oh, Cheong, I got what you're saying now. You're not just identifying gaps in care, which a lot of AI ML systems would do, right? Or even you just run a this annual wellness visit type algorithms, and you will be a surface guy. You are actually helping the team close the gap in care, right? So we are all about taking the actions, this collaborative care. And then we can provide a summary as well to them of the patients that they're taking care of. Here are the things that have been happening to them. And then we provide smart notifications in the summary. These are the patients who need the gap in care closed, or in other situations, this might be a person who has an appointment tomorrow, but there's a high risk of no show. So that will show up as part of the notifications as well. Then to them, this bottom chart over here is about the milestones. Remember that subway diagram, those are the different stations. What they want to know is who got stuck at which stations. So it might be, one of the stations might be testing. And yes, I sent this Mr. Smith over to Westlake Test Center 3 weeks ago. And so what's happening now? Did Mr. Smith come back? Did the test results come back? Did the doctor interpret it? All that kind of stuff. So I have a box over here, and let's say 72, and Mr. Smith is still in the list of this 72. I know he's stuck over there for 3 weeks. So this interface is still being used until today because it's analytic and AI right in both. So far we talked about the different systems that bring the different interfaces that bring the insights and activate them, right, for the care team. How do we actually do the tracking of patient statuses and surface those important tasks for the team? Before our engagement with the team, the medical directors and the teams follow this more conventional approach, right? So for those of you in healthcare, you know about lean process improvement, and that's pretty popular. So they get everybody together and they talk about plotting out this, or drawing out this swing lane diagram, right? From the top to bottom is the different parties, from the front desk clerk all the way down to patients themselves. Who's doing what. And so this is kind of like, passing the baton, right? One person to another to another. And the whole exercise over there has a lot of emphasis on reducing waste. Right? And then waste, from lean standpoint, is what they call the muda, mubra, and mubri, right? And roughly speaking, what it means is wasted efforts, non-standard process, and non-standard work. So if you do any of those, you get a lot of waste in the system. So their approach is, let's go through this, pare it down somewhat, and then that will surface the solution attributes. And then with the solutions attributes, then we go out and look for the solution that may have match. What I'm asking here is, are we limiting ourselves, looking at things that way? And when I say this, I remember 20 years ago when I started to learn skiing. What happens was, my instructor said, Cheong, to go down this slope, you would do S curve, right? And so I'm like, oh yeah, I can do S, right? Because I already got my turn down. So I'm, kind of following my way that I have learned from when I was a baby to whenever whatever I was, I nailed that running around in S, right? So I threw my body into every turn like that. And a lot of beginners would do that. Of course, I could only get to some intermediate slopes, and I couldn't do at all, right? Those black diamonds, really steep slope. And then years later, I found out that advanced skiers are skiing with their ankles. That's all they do. I'm doing this. So it is a new skill. And AI, right, especially AI with this workflow context, it is a new skill. So if you want to get to those black diamond slopes and ski down like a pro, you got to learn the new skill. Here's a little more details about that. You know, traditionally you have this model that's built perhaps using patient attributes. If you are bold enough, you get into the NLP, right, natural language processing side of things, and start parsing through the nodes, extracting the features, and then you may incorporate testing data and imaging data. And then let's say what we are classifying here is the high risk, medium risk, and so on for non-adherence, meaning the patients take the devices home or the treatments from you, from your prescription, and then they don't really use it. And what we figured out is with interaction data, workflow steps, and the details, we actually can predict better non-adherence. And how so? It actually makes sense because, for example, if you have a patient who has many cancellations, who had a couple of no-shows, that shows a little bit about how enthusiastic they are about the treatment, right? So if that is learned by the model, then you can use that to say, well, there's a high chance this patient is not going to be adhering to the treatment. And what can you do with that kind of information? The one thing that I could say is there could possibly be some steps in what you do that's unnecessary. And you can do that by studying the feature importance. Then the same feature importance can tell you whether there is some alternative steps that someone on the care team might be doing, like perhaps following up with the patients more frequently over a 1-month period after they got the treatment, right, versus the standard perhaps 2 weeks process that you're following. And hey, you know, if the 1 month follow-up is more effective, maybe that's what you're going to institute into your process. And another use, it could help you determine what is the optimal next step. So using the adherence example again, so at that point over there, if you have an enthusiastic patient about the treatment, then perhaps treatment workflow number 2, no monitoring required. That's what we're going to be following. Right? If it looks like this guy is high risk, then you might be putting your best staff and go all the way up to the top pathway over there. If you're interested in the technical details of this kind of usage of AI with you know, workflow steps and so on, there is some literature. It's not healthcare specific. It's for business process monitoring. You will be able to get a lot more details than what I covered. So great. Now you figure out who is at risk of non-adherence. What can you do about it? And our system is all about putting insights into actions, right? And so we actually have the way of, with a workflow context, figuring out, okay, you have a team of people, the care team, and the care team has different roles, and then different roles is doing different workflow steps. Then with that information, you have a high-risk patient, you know which one is the next step, then who on the team should be working on that. Right? So this is how we bring together the different people. We even have a collaborative interface that looks like, I don't know if you guys know about Trello or Asana, right? Those are the online collaboration, online project management collaboration system. Except that in this case, each patient is a project, right? And those kind of systems won't work because, realistically, for a reasonable person or typical person, right, not God, right, like us, you can handle, 20, 30 different projects at a time, and you're talking about thousands of patients that the care team has to handle. And then with this outreach, care team engagement, and we're really talking about, here is the action. With a prompt, I can ask you, first of all, is this prompt good or not? You can say yes or no. This is not correct, this is not useful. That's fine. And then the second thing is, are you going to take an action? Are you going to do something about it? So that action and yes or no on is this useful is all fed back into the model. And with that, when you do it in a continual fashion, and you improve the model, because those the care team members essentially are providing you with the newly labeled data. So at a high level, this is how the architecture looks like. Pre-processing on the left-hand side. Obviously we also accept data from medical devices from the patient's home as well. And then in the pre-processing step, we include the workflow context. So we're hunting down on where the patient actually is right now. And then this interaction models are really the thing that's driving the prompts with the care team. And then you can see on the right-hand side, it's doing much more than that because it is also looking at your communication preferences, right? Do I talk to you over email or over SMS or some other ways? And then I could be talking to not just the care team, but the patients, the caregivers, all a system. So that opens up all the opportunities for automation because I could be checking insurance rate. I could be sending out SMS to the patient, right? And hence I have this slide over here. Now we're tapping into the whole development of the API economy over the last 10, 15 years. Automated texting, email, insurance checking, everything is fair game. So to recap, we add to this more traditional pre-processing training and deployment of models with workflow context, and then with interaction models, and then with this continual improvements to allow us to be this more active brain that is continuously developing or renewing itself. And I think about the term AI encapsulating the workflow, but simply I just call it workflow AI. And for those of you who program in PRS and understand TensorFlow, LSTM, this is roughly the picture of what we do in the backend. And results. For the specialty care clinics, we cut down from 300 misses in a year to 0. And then the care team members are spending much less time doing patient status tracking, researching, from 2-3 hours to about 1 to 1.5 hours. And then 50% more capacity, from about 750 to 1,100 plus. And then in the second use case for the chronic care management, now we have 20 nurses working with over 5,000 patients. That goes from about 100 per person to more than 250. So the possibility is endless. We already talked about automation features important, how they help us improve the process. And what about A/B testing? You can have a group of patients going down pathway A and then a group pathway B. Now you have a very good comparison of the two, and then you will be able to find out what is best for perhaps my resource utilization, for my my goals that I want to deliver on my patient outcomes. So I have to stop here. Thank you for your attention. And if you have questions beyond this, our conference over here, please send me an email or link it with me.